evening, everyone. I'm Dr. Amit on behalf of Team US. We welcome you all for today's session on digital technology in medicine, a hype, hope, or reality. To initiate the session, it's pleasure to introduce our moderator, Dr. N.K. Singh Sir, who is a director of Diabetes and Heart Research Center, Dhanbad. Sir is also a chairman of RSSDI Jharkhand for the year 2019 till 2023. He is also an executive member of National RSSDI till 2025 and ex-government body member of National API as well. He is also an ex-chairman API Jharkhand
Yeah,
NCCDSI.
Amit, can you skip?
Yes.
Yeah,
So
I think,
with
yeah.
this, I would like to hand over session to Dr. N.K. Singh sir
Yeah.
to take the session forward.
Yeah, thank you, Dr. Amit. I have great pleasure today again to welcome you all my learned audience. Today we got a speaker from the Denmark, and I think we are going to today discuss something unique in the field of digital technology in the medicine. Uh, what is the reality, what is the hope, and other things. And we have got so many important and eminent personalities from the India today. So, can you, Amit, display
Yes.
the CB PPT of Dr. Kulkarni?
Yes.
Yeah, so Dr. Bijay Patni is here also. So I welcome you all. As you are well aware that Dr. Kulkarni, can you go back?
Yeah.
Yeah. So he's the Vice Chair, Diabetes Technology Work Group, Diabetes India, Professor of Medicine, Unit Head, MGM Medical College, that is Nerul, Navi Mumbai. He has got lots of experience and pioneer and proponent in digital medical technology in IT and AI. Also, the editor-in-chief ICP monograph on digital technology. Rather, I can say that he is the father of digital clinical technology and artificial intelligence in India. And no conference in India today is happening without his support and without his presence. So, this is a great thing. And second, our today's moderator is Dr. Chaitanya. I think, can you go to the next? Yeah. So he is also active in medicine, education, disability, innovation, cyber law, charity, IT, networking, and environment. And I think he is also a great person in the technology field today in India. You can see here he is the executive director of the Wheels Global Foundation, focusing on telemedicine and technology, enabled healthcare, and top 100 healthcare leader of the AIFH award. So next, welcome Dr. CS Book, and next we will also got Dr. Akash Singh. As you are well aware, he is a senior consultant, medicine, diabetology, and non-interventional cardiology, Baroda, Gujarat, and national, regional, and state conferences. He is already invited faculty, and he is doing great. So next, can you next and next, Dr. Bijay Patni is here. He is the now at present the HOD of the Diabetes Wellness Clinic, Kolkata, and I think he is one of the a pioneer person in the conference age and digital technology also. He's doing great and lots of awards, lots of research, and always doing something for the betterment of the society. Also written a book on the diabetes that is very important. I have seen it. So welcome Dr. Bijay Patni, and now I request Dr. Bijay Patni to introduce today's speaker, Dr. Patni. Yeah. So can you display the slides of, yeah. Dr. Patni, can you start?
Okay. Good evening, all, and thank you, Dr. N.K. Singh, for introducing everyone. And we have stalwarts like Dr. S.V. Kulkarni and Dr. Puch today. So now we have Dr. Khushbu Verma from Denmark. She is going to decipher some of the myths and facts about digital technology in health. She's a seasoned digital transformation leader with 21 years of experience in health tech, specializing in clinical digital implementation and telemedicine. Founder CEO VK Denmark developed digital platform Cordia for chronic disease management, maternity care, AI-driven diet management, and research data collection and analytics. She's member Indian Denmark Chamber of Commerce. She's a group leader, Women in Life Sciences Denmark, member Federation of Danish Industry, member and speaker of Telemedicine Society of India, and has key expertise in clinical digital transformation, telemedicine implementation, optimization. I think the topic need to be changed. She probably is going to speak for the topic, and we have two other stalwarts to add on to that. So, Dr. Verma, you're welcome on this platform, and please go ahead with the topic today.
Thank
you so
We're
much.
proud of your achievements. Really, a good shining Indian girl.
Thank you,
Very
sir.
nice.
Thank you so much.
Yeah.
I'm honored to be here, first of all, with all of you. I feel inspired to be surrounded with such a learned audience. I'll just share my screen and so that I can share the presentation that I have. So I'll start by saying that effective preventive and proactive healthcare is a team sport. Or the doctor, the patient, the relatives, the nursing staff, everyone has to come together to take care of the patient. And that is what digital technology can do, can help us with. How can we play this team sport together? Now that when I was introduced, it was said that I am going to speak in favor of digital technology, but of course, it comes with some challenges and some learning, some evolution process. I'll also mention that. But yes, I am a digital health tech person, so I am going to talk about mainly about the benefits and advantages that we can harness using digital technology. For the best clinical outcomes, it's important that all these parties work together, and that is what I have been trying and advocating for in Denmark and in other parts of the world, including US, UK, Finland, Canada, to promote digital technology into healthcare. Now it's a very responsible task, I must say, because patient safety has to be taken into account. It is the paramount thing which has to be thought of as first thing whenever you try to transform a conventional method to digital methods, or a conventional treatment to AI-driven treatment, and so on and so forth. It's a very responsible task and has to be taken care of in great details. So this is a question in front of me. Digital technology in medicine, is it a hype, hope, or reality? And I would like to use the coming few minutes to to give a global perspective around it with my experience from all over the world in this area. But before doing that, we need to understand what are the phases of digitalization. When we say digitalization, what does it mean? And most of the audience here might be aware of it, but we can divide the digitalization process in certain phases. And the first phase is digitization of records, where we transform paper-based records to digital records or computer-based records. And then the second phase is integration of systems. Now we have some digital systems, they don't talk to each other, but in order to have a good digitalization, it is very important that these systems don't act like silos of data, but they interact with each other, they talk to each other, and they connect with each other. And the third is patient-centric innovation. The third phase is the most important phase. That is where the benefits can be harnessed from this setup, from a digital setup. And that is where the patient can be taken care of in true sense with high quality of care delivery. It's not necessary that we have to do phase 1 and phase 2 in order to reach phase 3. If done smartly, we can jump to phase 3 directly and have patient-centric innovation implemented in the clinics without step 1 and step 2, which takes care of step 1 and step 2, by the way. So that is my perspective upon the phases of digitalization. When we talk about patient-centric innovation, what does that mean then? There are certain levels of engaging the patients, involving the patients into the healthcare. The first level is we are already there. In India, I have seen a transformation in the way clinical interventions were made, the way clinical consultations were made 20 years ago, 25 years ago to now. There is a huge progress, and technology adoption is, India is the best country for any kind of technology adoption. I mean, people just grab technology and try to experiment with it and use it. So that I don't see that as a big barrier anyway. But the first step of patient engagement is to keep the patients informed. to inform the patient about what is happening with their body, what is happening in their body if they are eating a medicine or eating a particular kind of food, what happens when they exercise, what happens when they sleep properly, and when they have a rhythm in their life. So all that information sharing, that is the first level of patient engagement, so that the patient understands their disease, they understand their condition, and accordingly can move to the next step, which is engagement. And why I'm telling these steps is, this might seem like common sense, but in technology implementation, this becomes very important that we follow these steps. We cannot shortcut to the highest step and start talking about AI and start talking about high technology, high tech, before taking the patients with us in that journey. So this is the journey of the patient. Engagement means that the patient takes responsibility in taking care of themselves. So they don't see their body as a car which needs servicing, and they come to the workshop, get service, fix things, and come back and return to their original behavior. They have to take responsibility and engage in their own health in order to reach the third step, which is empowerment. All this information and engagement will empower the patients to make the right choices for their lives, to in daily life, if they have a choice to what to eat, what not to eat, they can take the decision by themselves. And if it is a diabetes patient, I mean, there are multiple decisions you have to take multiple times during the day, in if you're insulin dependent, and if you are controlling your carbs or whatever, you can make the right choices if you are an empowered patient. And that is what we want our patients to be. And once they are empowered patients, we can talk to them. Instead of having a parent-child relation, we can have parent-parent relations, adult-adult relations with the patients, because they will be able to partner with us. And in Denmark, it has been a journey. And I must tell you, in Danish health sector itself, it took multiple years to reach this partnership mindset between doctor and patients. We are not fully there yet. Sometimes medicine is a black box to the patient still, and which is by the grace of complexity in medicine, it is fair enough as well. But anything that patient can control and influence in their daily lives, they at least are considered as partner in those areas. And the last part is supporting the community of the patients, which means that people around the patients who are equally enthusiastic about patients' health, how can we involve them? How can we use their energy to support the community around the patient? Now, when we talk about digital technology, there are some important considerations, and they have to be taken care of right from the start, because if we don't take care of them, it becomes a burden. The technology becomes a burden in the end. And this is something, it's coming right from an experience we have digitalized in Denmark, 98 municipalities and 5 regions of Denmark. And I know precisely what goes wrong if these things are not taken care of from the start. So delegation is one of the things, which means that technology must reduce the burden from the doctors, from the clinical staff, and distribute it either to the technology or some other actors like the patients themselves, like their relatives or whatever. There is also something with ease of adoption. The technology has to be adopted easily. It should not take multiple months to implement the technology, because then the technology space itself moves ahead. So it has to be easily user friendly. Usability must be very high so that the learning curve is not very steep for the clinical staff, and also for the patients if they are involved. Then interoperability is another thing, which means that the technology has to follow some standards, interoperability standards, so that whatever we bring, whichever solution we bring into our clinic, it should be able to talk to other solutions if needed. If there is a need that data exchange should happen, it should be possible to do that. So silo solutions are no-go. Then configurability. Even though we say that all the diabetologists, all the general practitioners, they practice the same way, that can't be true. Everyone has their unique way of practicing. Everyone has a unique episode of care or protocols to follow, and that configurability must be supported by technology. Data protection is very important, data privacy, because if we are talking about personal data, so it goes without saying. And industry standards, as I said, for interoperability, for being compliant with regulatory requirements as well. It's important that the technology that we use are compliant, are following some industry standards. Now, the last part, the fundamental part, is platform approach. If we always think of solutions, then what happens is that we get a lot of solutions which don't talk to each other, don't interact with each other, and it becomes a chaos. It becomes a burden overall. So platform approach is very important to be kept in mind from the start, something which can cater to more solutions, something that can embed the solutions instead of having one problem in mind and solving that using technology. So more platform approach in technology helps the clinics, helps the doctors quite a lot. So these are the some of the critical fundamental parameters that I evaluate technology with, or when we make it, we also take care of those things. So about the global perspective, in Denmark, I would say that it is Denmark and Finland are one of the most digitalized healthcare systems in the world. And it has been a journey for 2 decades that we have reached, or these countries have reached this level of digitalization. However, the digitalization pace in India is so fast that I won't say that India will be behind in any way in the coming few maybe months, not even years, I would say. So with all the AI revolution that is happening today, it is really great to see the progresses that we make. The future of health is actually digital first, especially chronic disease management is one of the areas where it is going to be digital first. And there are some countries which will be pioneers in that. Like I must tell you that last week I was in the advisory board meeting of for the digital health in the government, in the parliament, and they were what we discussed was that from 2028 we will be going digital first for all the chronic patients in Denmark, especially suffering from diabetes, hypertension to start with, but eventually all. So from 2028, digital first journey will start, meaning that the patients will be offered digital healthcare first before the physical healthcare. So all the doctors, all the clinicians, they have to equip themselves with technology in order to achieve that vision, in order to achieve that milestone in future. We don't know if that is the right thing or wrong thing, because if you think of human empathy, if you think of close contact with the patients and looking the patients into eyes and trying to figure out how is it going with the patient, if maybe the human aspects get a bit lowered in this, but at the same time, maybe the patients are getting used to it. Maybe the patients are ready to navigate in the digital health systems as well. So we will see. It will be interesting to follow for sure that how does this shift happens. So yeah, but it is not only a technological upgrade. It is a paradigm shift, and we will see that change coming up in India as well eventually. About the AI readiness, we also spoke about how AI is getting more and more popular. But again, there has to be, when it comes to healthcare sector, AI has to be seen as augmentation and not automation tool, which means that AI has to augment the services that we offer, the clinical services that we offer to our patients, instead of replacing clinicians from the equation. The human have to be kept in the loop in relation to AI. And I'm sure that most of our senior doctors who have worked with digitalization and AI would agree with that. And I'm looking forward to the questions and comments around this. But there are certain things that we need to take care of, that the digitalization should increase scalability, cost efficiency, system optimization, and improve patient quality of life. If these 4 parameters are taken care of using digitalization, it's a great thing. It's an achievement. It's a milestone. Plus, digitalization, when we talk about digitalization, it should not be seen as only helping the clinicians, but also it should be seen as helping the patients. That how can we help our patients? How can we help our patients' families, and in the end, the whole society, to lift their knowledge levels up so that they can take care of themselves more and more, and they can improve move towards more preventive and proactive health in consultation with the clinicians, in guidance. But at the same time, as a society, we evolve so that we don't make records in number of patients with diabetes and so on, so that we can improve the society, so we become healthy society or healthier society than today. So that is also the power of digitalization, that we can make people more aware and empowered. And as I showed those steps, we can help people reach those steps quite quickly with digitalization. Because if we have to do it manually, none of us have so much time. We don't have time to sit and educate and empower a patient, giving a lot of efforts and time. We are pressed with the number of patients that arrive in our clinic, the footfall and everything. So this is very important that digitalization is used as an augmentation to help us achieve that level of interaction with the patients. Yeah. So what does it mean? Now, to conclude the question, that is digital health a hype, a hope, or a reality? I would say that it is a hype when we try to oversell digital solutions and overpromise without knowing the reality, without knowing the field, without understanding the relation between the doctor and the patient, without understanding the clinic and so on. It is a hope when we see that some countries who have tried and tested it for last decades, they are getting good results. They are getting some good experiences which we can draw from, which we can learn from and bring them to our clinics. And it is a reality for sure when we see the progress already happening in India, in our clinics in India, where we see a lot of digitalization happening, a lot of initiatives being taken up, not only by private sector but also by the government. So that shows the reality. So that is my take on digitalization, that it is all a hype, hope, and a reality. Thank you so much.
I think, can you stop sharing? Yeah.
Yes, I would.
Yeah, so I think Dr. Akash, you are there? Yeah. So Dr. Kulkarni?
Here,
Yeah,
yes,
sir. So your initial comment on the talk and
yes.
situation.
Kushbu, first of all, appreciations for your unbiased views. You took both the sides of it, and now in the flow of discussion, we will come out to know how you did it and how you can tailor make it for the Indian settings. Because in India, the biggest problem is the number game. Doctors saying, Bush, me, Asha, so everybody must be seeing at least 50, 100 patients every day. So there, your first dictum, digital first, physical later, will be of really very help if we start adopting that in a better way. Because triage and picking out the odd person, suppose if somebody, in severe, I work in a medical college. What are the complaints of my patients? Haath pav dard hota hai, head sar dard hota hai, sardi hota hai, they will tell you everything. But if if the patient says that he cannot sit up from lying down position, or he cannot wake up from the lying down position, or he has been brought by people on stretcher, I must say my antenna should have, this person should needs to be given first choice. So that is a very good frame of a word which we have used, digital first, physical later. I am going to use it.
Yes,
Then the second point, what you said, that system optimization. Now in system optimization, I have got something called as a weapon against system malfunction.
yes,
A system malfunction is one of the biggest, it's a nightmare for everybody. Even if my net goes off, I have got two other phones on which there is an internet, but it may not be that strong. So the communication may not be good. So the negative point, people say that you are too much dependent upon technology and other things, and they will be the last minute you will have that problem. Okay. Then there is one concept which I think everybody of us should discuss and come down with a common conclusion. It's called as a data repurposing.
Yes, yes,
Dr. N.K. Singh has got a very good project that soleus pump exercise alone, 100 times done 3 times over a period of 3 months can reduce HbA1c and lipid profile. But what will happen to my consent of these people when I repurpose the data in the either in the variation in the problem or variation in the solution?
yes,
Okay, that means you cannot say patients when the question of confidentiality and consent comes, that you have to tell that I am going to use it for this particular role.
yes,
And we are getting more aware at a better speed,
yes,
but that speed should be sustained. And Dr. Singh, I'll tell you, it is difficult to sustain the speed. I just today got a flash of mail from JAMA, and I can share with all of you, which you can share with all our members. There are 4 fantastic articles, absolutely crystal clear articles on that. I'm going to tell only 2 or 3 points out of it, and then after going, I will allow Dr. Chaitanya to speak. The sustainability point I talked about, security risk, the data should never leak out. We have got, we have to ask a question. Do we have a limited oversight? Do we have a limited oversight on this particular problem? And are we creating a digital divide? That means the people who are accessible with digital technology, AI, and those who are not available with. So my points to ponder is limited oversight, digital divide, then data repurposing and variation in the problem for the same data solution. Each one by one, each we can take it down because these are very practical things. And the research and the data is going, if it is employed by all of us with AI aided tools, no doubt the speed is going to be absolutely fantastic. CME India can come out with 2 research papers every week. So with this, I stop with appreciations to Khushbu, Dr. Singh for organizing the platform, and over to Chaitanya.
Yeah, Dr. Chaitanya, your comments.
Thank you, Professor Kulkarni sir, Khushbu, and Dr. Singh. I would say that what she has narrated is absolutely perfect. And I can tell you that for me and Dr. Kulkarni, who have been, say, we are almost 74, 75 batch, so 50 years. And in that, in last 40 years, we have been doing absolutely the same kind of thing, what Khushbu was showing. So for informing my patients, I will narrate it the other way, that what did I do? So I have year-wise groups of diabetic patients and I inform them about their problem. If it is diabetic peripheral neuropathy, they'll get the details and videos and informations in 14 languages in their language to their mobile number. So then empowering them, and also now partnership, that my patients with paraplegia, one of them, we have worked with them with Innovation Council, and we have prepared a FES bike. So functional electrical stimulation bike we created with the patient, so that while sleeping in the bed with paraplegia, he can earn. So absolutely the right way to go, what she told about Denmark. Another thing, that the word that I use, that who are the people who have patient care in mind. And my word acronym is MIND. It is the medicos, interns, nurses, and doctors. And the program that we develop has to be available, accessible, affordable, and it has to be so easy that training part should not be too much, as she rightly pointed out. I would also say that the technology use is so much helpful, and especially with the narrow AI, which we are using currently. Then we have AGI which is generative AI, and then the last one, which is a spatial AI, that will be for later time. But currently, doing triaging of the patients with narrative or narrow AI of the current type with the chatbots is going to be absolutely doable, and we must do that. So I think that with these things and with AI, we are able to give patient information and videos and literature. If I had to share with you on audio, what is data? कुलकर्णी सर, पहले ऐसा था कि हम कहते थे कि भगवान देता है, दैट स्पेलिंग देता इज DATA. नाउ भगवान डेटा नहीं है, डेटा भगवान है हमारे लिए डिजिटल मेडिकेशन में. सो डिजिटल मेडिसिन में we run currently the phygital clinics where the patients come another, and then they are seen and then digital, as opposed to what she told, Dr. Khushbu, you told about digital first. Now, another point raised by Dr. Kulkarni is that people digital divide. So our solution for that is that I have 33 sevaks who are 12th standard students, and they are there just to take care of the divide. What they do is they are situated in one district, every district of Gujarat, and they have the mobile which is smart mobile, and they meet the patients, take their interview, ask them questions, whatever are their problems, they connect to us, and we even provide in various. So during COVID, we provided in their mother tongue. So in Africa, we saw in Swahili, because we have an intermediate person whose intelligence and translation we utilize before the AI translations came. So we saw 800,000 patients world over online in their own language. So that is another good way to meet and avoid the digital divide of a patient who is in the last mile. So we have a clinic in Rajasthan, in Alwar, 5 clinics in Uttarakhand, and almost over 30 and 20 projects. Now, audio, when we talk to ASHA workers and Anganwadi workers and tell them about breastfeeding and malnutrition treatment, we have with us in Malnutrition Council, Dr. Rupal Dalal, and we have created the first village in the country in Maharashtra, which is totally newborn malnutrition free. What I'm trying to tell you is not what we have achieved. I'm trying to tell you that technology, because with IIT Powai, we developed spoken tutorials, and in several languages, 100 spoken tutorials. With that, one village in the country for the first time has become malnutrition free. We wrote letters, we got this evaluated in US, and impact study was shared with the chief ministers of country in India, and we got a project from MP where next 1 million births will be dealt with, newborn malnutrition will be dealt with by our Newborn Malnutrition Council. And hearing this, a team from US decided to donate 4 crore rupees for the work. So what I'm trying to tell you is that good work with an intention to improve the patient outcome and not focusing so much on our income, money is not a problem. With, as a chairman of Vadodara Internet Promotion Forum, I have been saying, and you all know it, that with internet, geography is history. So it really doesn't matter where we are trying to treat. So you can be anywhere, doctor can be anywhere, language can be any, and we can take care. So I would stop here and keep further discussions if required in further.
Yeah, so Dr. Amit, if there is any chat box question, let us know. So you just see that. So I think there is a great discussion here, and Khushbu, you definitely give a very important and very, I think, focused view. But let us discuss some practical things which is happening in India. Many of the doctors today are afraid of using the AI. Uh, Suppose I am running at 12 groups of the CM India, and lots of question I get it. And when I go through initially I was going through the Googles, reading that, and then extracting the knowledge, and it was a very, very time taking. Now it is only thing that the AI use is very, very important in my practice today also. If you see about the machine learning, I do my echo with in my clinic with diabetic clinics. So this is now AI enabled. So it has become so fast that you just have to freeze the image and AI gives you all the values. In the same way, we are also using the fundoscopy part was very difficult in earlier, but now today what we do that we have got a fundus camera, AI enabled, and we get a beautiful picture image, and we get also the remotely someone is sending us the interpretation of that report also. So this has become very reality in India these days. And I have, whenever I go for any queries for the CME India, I think only thing that you have to verify that the AI which is giving the answer is justified or not, is it true or not? Sometimes there is mistake. So what I do that suppose I have got any doubt, suppose from the chat GPT, I also use the grok of the X and I have found it very good. So I think there are two or three AI I am using. So I think Dr. Kulkarni, can you give some practical aspect for using the AI for our physicians at present? And then Khushbu, you will comment.
Uh, Khushbu, before I just take over the situation what Dr. Singh has told. Now we all, Akash, me, we are treating hundreds of diabetic patients. My simple concern is by using the glucometer readings, by knowing the tablets, what type of medicines he is taking, and by monitoring the steps of the patient or level of exercise or the heart rate which comes from a smartwatch like this, am I in a position to predict hypoglycemia? Akash, this is a very particular problem for all of us.
Yes.
If we can tell that either you are likely to have a hypoglycemia or whatever the reading that the things are there in which you are going to need adjustment of the medicines. And Dr. Singh, about how to make people to use, promote AI, first of all, this is not at all a rocket science. It is absolutely simple. Your WhatsApp uses, the moment I type NK, Singh comes in my predictive typing. So we have to find out what we want, what we have, and how we increase the process. And digital technology in form of electronic health record, getting the graphs of the patient's blood sugar, cholesterol, that really impresses them. So even even with the CME India platform, if we can come across something simple A4 size patient records, in which the first part will be all the comorbidities, second part will be the sugar value variations, third part will be the medicines, and fourth part can be follow-up and the vaccination schedule. It will help to get the people vaccinated also. So it will be a sort of a monitored care, and the patient himself may ask that, doctor, you have given me flu shot last year, but what about my 2025 flu shot? So, Khushbu, how you had done Denmark? I know that it is a very disciplined country. No problem of, no doubt of it. We have got our own problems. But can you find something in between? सुवर्ण मध्य जिसे बोलते हैं ना, वो सुवर्ण मध्य आप कैसा निकालोगे? And
Yes.
Dr. Singh, I got one more suggestion. Now you are owner of a dozen CME groups. I wish you that you should celebrate a silver jubilee in 2025. So nice.
Dr. Kulkarni, there are lots of questions now. Also, we have to see the
Yes.
chat box, Khushbu,
Yes.
Answer, and then see the chat box. Yeah.
Yes,
Just
Khushbu.
one comment quickly around, sir, it was such a good point that you made in relation to this A4 size EHR system or
Yeah.
A4 size. And that is exactly, I mean, I'm so excited to hear that because that is exactly what we do, but that's another story. In Denmark, one thing is that took time, a lot of time, is the behavioral change part, sir. So the behavioral change in from both the doctor's side and the patient's side, that was not that easy, I must tell you, because it might sound discipline, might sound more in Western context, but adoption, technology adoption, and learning and having open mind to new things, that is discipline is kind of against it. Discipline restricts you to your thought process. So that change is has taken time. The sweet spot would be that we create something which has engagement by design, which has a technology platform which has compassion and engagement by design built in it. And it is possible today in AI world, it is totally possible to have that human touch as well in the technology. So that is my answer. But we can, I mean, this is a topic that I can talk a lot about. I'll stop here and instead answer the questions in the chat.
Khushbu, there are lots of questions. So
Yes,
first
yes,
question is, how do regulatory bodies like FDA, EMA, or CDSCO assess and approve the digital health technologies?
yes.
So first you go for that.
Yes. So, in case a software or a digital platform is software as a medical device, is it called SAMD, then there are certain regulations that the software has to be compliant with. There are certain standards, like if you have heard of FHIR standards, the interoperability standards they are, and then HIPAA compliance, and there are certain compliances that you have to live against, and then ISO. There are also regulatory requirements in relation to ISO 13485, which is the QMS certification, and then IEC 62035. It is also another software development process standardization. So there are certain rules and regulations you have to live up to in order to be compliant, in order to even apply for these certifications, like MDR, it is called in Europe, medical device regulation. That is what MDR is. If you are compliant with MDR, FDA is not a problem, but FDA is similar for USA.
For
So Dr.
India,
Chaitanya, Dr. Chaitanya, can you
yeah,
see some questions by the Dr. Ajay Gupta and some comments? Can you see that?
yeah. First, I would tell you that at India, what she talked about MDR, same way at India, for people who afford and for people who do not afford. People think that the Mukhyamantri Yojana or Ayushman Yojana is only for poor people, but Abha ID, all those who have Abha ID, in those Abha records, we can be made Abha compliant. And once we are ABDM, then our data and everything is as per what is required internationally. So I would suggest that number one, Abha DM and Abha is the one which people can read. The second thing is that once we are Abha DM and we have an Abha ID, we do not even have to enter the details of the patient, and all his past consultations in Baroda, in Bombay, in Boston are there on the same record. And every day, minimum 90,000 to 1 lakh patients are being added, and more than several crores have been added. So the problem of computerization of the data has been done to a very large extent, and there is another Mr. Singh and others in Abha who are also very proactively working towards this. So I would say that that is what will be the way to go at India, right?
Yes, yes, sir.
Yeah, so I think Dr. Ajay Gupta has given some few comments also. So I think he has something talking about the individualized approach to cancer patients, how to manage, and also asking something about body metrics, which a
Yes.
small pad people can stand on daily to detect foot ulcers. Oh, that's okay. But basically, the Dermavac vision, which is a combination of non-invasive derma flow technology, he has informed. And but basically, the question is the future of the cancer diagnosis, AI, visual biopsies, and molecular profiling. So, your comment, Dr. Chaitanya and Dr. Kulkarni
Yes.
and Khushbu.
Yeah,
Yes.
I would share the hype, the hope, and the reality. The reality is that future of cancer is going to be very good. Future of cancer medication development has become very fast. I'm not going into the details and the names of the program. The detection of the cancer, say CA breast, 5 years earlier, because of the use of AI, over and above that of the radiologist's eye and brain, is also, as of now, a realized goal. Another thing that we use in technology and PhD in computer imaging, people in National Library of Medicine and NIH National Institute of Health, they have 1.3 billion images. And from that, they can tell you that automated diagnosis, that if you have 10,000 patients with cervical spine photographs and you have taught them how many are cervical spondylosis, a whole list can come. A peripheral smear or even a pap smear, CA present there, CA cervix, grading and automated reporting. All these things are happening today. And we have done a comparative analysis of e-smear, of pap smear from a village in Gujarat to Bombay and also in Arizona, Phoenix. And all three report within 8 hours with and without AI. So I would say that cancer diagnosis and cancer treatment and personalized therapy is going to be very, very fast and very, very significantly up end and helpful to all the patients, not only somewhere else, but also in India.
Yeah, Khushbu, the Ajay Gupta is again asking very important question that in healthcare, current laws are not enough to protect an individual's health data. Even the robots can be hacked and many other things are happening. Even for the some genetic testing and bioinformatics company, they not legal or closely monitored. So what is the answer for that?
Yeah, so health data protection is a very big thing in Europe. If you think of, there is something called GDPR, General Data Protection Regulation, and GDPR is taken very seriously. And I think we should have similar setup in India as well very soon, where private companies are heavily penalized if they are found using data in illegal way or immoral way, I would say. And that is what GDPR does in Europe. So it is about policy making. It is about creating, governance around data, and technology. Of course, today is in a state where data privacy can come by design. So I would not be worried from technology point of view. It's more about the intent point of view. There could be worries, and that should be governed and that should be regulated by the government policies. So I would say the answer to that is the policy making, and that is what it took a lot of time in Denmark as well to interpret GDPR in the correct way and let the private actors play in the healthcare space, abiding strictly by those rules.
So Dr.
We,
Kulkarni, I think again for
yes,
a question with
yeah,
by please
medical
answer that can
oncology or the
you please
cancer.
hear. Yeah, Dr. Kulkarni, this question again that can digital health truly reduce healthcare cost or does it create new financial burdens?
It will definitely reduce the cost. I take help of the previous question. That is the role of oncology. And I can give you an example which I have just experienced in last 24 hours. There was a liver biopsy which was not, had very conflicting interpretations. It turned out to be a condition called as hemangiopericytoma. And not only that, after doing the genomic analysis, one organization suggested me the MAB, monoclonal antibiotic, which will act only on that malignancy. So, in the word of Martin Luther King, we should always have a dream that our cancer patient should not lose a single hair. He should never develop a stomatitis. He should not lose his skin, but he should have targeted treatment. And that precision medicine and targeted treatment is going to reduce not only the costs, but sir, the sufferings. You have to see the malignancy patients from a close angle. It is not one patient's disease. It is the whole family which gets affected. So 100%, if applied properly, it is not only going to reduce the cost, but the suffering and the outcome also. A complete remission was possible. One of my classmates, he had monomyelocytic leukemia. He went to Yale University genetic laboratory testing there, and he's totally cured now of that monomyelocytic leukemia. It's a miracle. Previously, the half for 5 year survival used to be 15 days after diagnosis of the disease. And he is now well with us for last 6 years. That's
Yeah. So I think you answered very well.
Dr. Kulkarni, can we ask Dr. Verma that how can we set up this digital health clinic in a normal hospital?
Yes, please.
I can just quickly answer that. And that is, so again, as I said, the implementation part should not be too long, which means that the digital technology in itself should be having this kind of automation. There is automation in implementation, meaning that it should be able to implement it by itself. And the education and onboarding part should also be very low effort, requiring very low efforts. The thing is that how to get started is, as I showed in my slide, there were 3 steps: digitization, and then interoperability, exchanging data, and then the third part was patient-centric innovation. And I can tell you, like, this is in some Indian context, I'm doing this, but I'm not here to talk about the platform. But it can be done within a click if it is done smartly. In today's world, it is so easy to start out a clinic on digital journey. And we have done it multiple times, both in the West, but also in India. So I have my experiences. But Dr. Akash, I mean, it can be done very quickly that a clinic is set up for a digital journey, and that is for sure. I mean, it's not a time. It should not be a time consuming if technology is done properly and automations are taken care of during the development. It's not a huge. It should not be a huge process.
Ma'am,
Okay,
So,
yeah,
who should be contacted for setting up a digital clinic?
Akash, there are few questions.
Who should be
Please,
contacted? Huh?
you first let us discuss the questions by the
Yes.
audience. The Sanjay Sukla is asking, how can we balance the need of medical data sharing for research and AI training with the right to privacy?
Yeah.
Khushbu?
So privacy is a thing that protects individual data. But when we are talking about research data, we are thinking more of population data, right? And that can be anonymized, that can be pseudonymized. So we have to remove the private details of a person. Anything which leads to a person, which takes us, to a private person, it should not be allowed. But population data is for everyone's good. And if we want to do research with this, it is also ethical. So anonymized data or pseudonymized data, that should be used in order to do researches, not private data.
And one question is, Ajay Gupta, how is patient data is encrypted and secured in digital health platforms? Can be shared or sold?
Well, and that comes to the intent. It's not about every platform can be developed in a certain way. There is something called role-based access control, RBAC. So digital technologies who are not having RBAC is a no-go. We cannot have digital technology where anyone can access, our whole database. So that is one thing that I always keep in mind, that role-based access control is the key thing. But in case the people having the access have malintentions, nothing can avoid that, nothing can prevent that except good regulation and good governance, as I said. So
Yeah,
it
so
can
Dr.
be
Kulkar,
definitely
yeah. So
misused.
any
Yeah.
comment, Dr. Kulkarni?
Yeah, what she said is absolutely right. There are 2 or 3 levels in which
Yes.
we anonymize the data so that the source is not hidden. Now, one more question, what suggestion that what Khushbu asked, told about. First, start keeping digital data. That is most important. It can be in Excel format. It can be any EHR format. And Dr. Singh, if you can recall, in Diabetes India, you talked about non-ketotic complications associated with SGLT2 inhibitors. So, suppose I have got 1,000 patients on SGLT2 inhibitors, and if the similar type of symptom comes, that extreme weakness, dehydration, inability to get up, in my EHR, it will give me a prompt that suspect ketosis in this patient. The second thing which every practitioner in India who is now listening to this webinar, keep your prescription in PDF format or in Excel format. Go to any generative AI like ChatGPT or whatever it may be. Just put that prescription, add to that, and give them a prompt. Prompt is the most important things. In AI, AI runs on prompts and intelligent prompts. Analyze this prescription in view of prolongation of QT interval because this person has got a history of sudden cardiac death. And if I got azithromycin, if I got domperidone, if I got doxycycline, if I got derifylline, along with beta blocker, I am enhancing it will give you all red signs that there are 5 drugs which can prolong beta blocker, so modify your prescription. And sir, this is a very important point in geriatrics. Not only in geriatrics, but all these marathon goers, deaths and other things. The people use drugs in an indiscriminate way and they can precipitate sudden cardiac deaths. So you can pick up any report, it can be analyzed. If you have got a very long article, PDF article is to be selected, you put that article and give the prompt that in view of this point, you tell me, and it will give good answers. It is AI has to be learned. It cannot be taught. It is
But
as simple as riding a horse. You have to
right.
fall down once or twice. Then only you can.
Sir,
Yeah.
Sir, good programs have now built-in internal editor which will prompt you that of the 3 drugs out of 5, there is interaction and it will be showing you red label. So Akash problem was that he has digitized, but the different providers do not provide a common interaction with so do not start a new program, use your own data and create a link to talk to that data with digital clinic, and then there will be no problems.
Sir, I think
Yeah.
that we all of us need guidance about starting digital clinics. Majority of us.
Yes,
Otherwise, it
Yeah,
will
that's
not start.
true.
yes.
Yeah, Akash, we got 4 minutes left. So I think Ajay Gupta has given some comments on the molecular profiling and other things. We are thankful for that. With that, Akash, before you conclude the whole seminar or sorry, whole webinar, I think Ravi, that in the same time, the Ravi Sharma has asked one question: Who is legally accountable if an AI powered digital clinic misdiagnoses a patient leading to harm? I think
Yeah.
again a very important question. Dr.
Yes.
Kulkarni, this is
Yeah.
goes to you.
If you put the symptoms in a very, very systematic way, with its all the ramifications, means chest pain associated with backache and severe sweating, normal ECG, abnormal pulses, and abnormal blood pressure on both arms, it will give a hit back that the suspect dissecting aneurysm. It
But
is.
Dr. Kulkarni, suppose even if I am using a AI powered digital clinic, I have got it, suppose, and if there is some problem legally, I am bound to deal with that because every time you cannot go blindly behind the AI. We have to apply our brain also. The human touch is also necessary.
Any AI output, the responsibility is of the doctor. So it has to be
Definitely.
one word uh, that is a data to human verifiable research output. Human verifiable research or clinical output. It has to be verified because
Yeah.
there is something called as hallucinations, and I think Khushbu can tell it better than me.
Yes.
Please.
Yes,
So
sir.
Akash, I will tell you that please ask for the take-home message from each of our moderators and the speaker, and then you propose a vote of thanks with conclusions. Yeah,
So
Akash.
I think digital health technology is very, very important in today's world, and everybody should be focused to this basically. We will learn in due course of time how to integrate digital health technology into our center. And second thing is that in India, the data collection is very, very poor actually, and majority of the studies are done in the European countries and the Western countries, which is basically because we don't integrate digital technologies into our practice. Once we integrate digital technologies in our practice, we have, I think, the largest data of patient available for variety of diseases, and this will be basically going towards a massive publication base for Indian authors, and it should be integrated in our clinical practice. So this all is also going to help the patients basically do better as far as their management of chronic disease is concerned, especially chronic disease. For prediction of chronic disease, for management of chronic disease, everything is going to benefit with the help of digital health mission, basically. I thank Dr. Verma for a very, very lucid and very, very comprehensive presentation about the work she is doing in Denmark and the work she has expanded to India, basically. Anybody who is interested in digital technology can contact her through CME India platform, and she will be happy to set up the digital clinics. I thank Dr. C.S. Buch, who is the stalwart of the city I am practicing in, Baroda. Basically, I know of the times when medical students used to go to find references for the thesis to him. He is in the computer education since ages, basically. I also thank Dr. S.C. Kulkarni, who is again the pioneer and I think the father of AI in India, basically. And his efforts have borne, and a lot of his students basically are doing terrifically well, basically, as far the AI is concerned. I thank Dr. N.K. Singh for coming up with
But
such.
Akash, have you taken the take-home messages from all?
I think I will like Dr.
You,
Verma to give a take home message, followed by
yeah,
Dr.
both. Yeah, I
Kulkarni,
think let us start with Dr. Burma, then Dr. Kulkarni, and
then
Dr.
Dr.
Chetan.
Buch.
Yeah.
Yeah.
Then Amit
So
will end. Yeah,
yeah,
Khushbu.
yes. So my message is that digitalization is a journey, and let's get started on it. That's it,
Yeah,
in
that's
short.
great. Yeah.
It is an augmented intelligence. We are
Yes.
all intelligent. It is an augmented intelligence. It is a process of development, and the way in which we practice in last 10 years going to be different in the next year what we are practicing. So you have to adapt to it. Start using and adapt to the data in a very, very basic way with the AI tools that will help you that good kick off starting the process.
Humans are parents of technology. So do not be afraid of technology. Try to be a floater. So every year and every decade, water level, technology level will increase. But if you are at the top of the water, you will be fine. And about hype, hope, and reality, it is like marriage. And you have all the three things in the marriage and in technology. Thank you.
Akash, anything to again? Have you given your message? You have already given. So I think with all the thanks, thank you that I have disturbed you from your vacation. So enjoy that. So
I,
Amit,
uh,
yeah,
uh,
yeah, Akash.
I thank Dr. N.K. Singh for conducting such innovative CMEs every month. I also thank Dr. Vijay Patni for being there and being the moderator for all of our sessions. I thank the USC to provide the platform for conducting all these innovative and independent meetings, basically online. I thank all the audiences. They are in thousands, basically, who join and ask the questions, interact, and make these sessions interactive and boost our enthusiasm and confidence in conducting future sessions. I will now hand over the session to Dr. Amit to formally close the session.
Thank you, everyone. First of all, I would like to thank Dr. Khushbu Verma for such an interesting topic. She have explained all the important pointers and addressed all the issues. And I also thank our moderator session, Dr. Singh sir, for taking such a wonderful initiative. And every time it's new topic to discuss. And also thank our expert panel, Dr. Kulkarni sir, Dr. Chaitanya sir, and Dr. Akash Kumar sir, for wonderful giving their insight and proactively moderating the session along with Dr. Singh sir. With this, we can conclude our event. Thank you very much. Thank you. And it was
Thank you,
really
thank you,
interesting session.
thank
Thank
you.
Thank you.
you.
Good
Thank
night
you
to
so
you
much.
all. Thank you, thank you,
You
thank
are
you very
just
much.
showing something. This is the light which I was using from behind my things.
Yeah, yeah.
This is called as a makeup light.
Yes, sir.
Yeah.
So it is
Okay.
like good. Yeah.